Okay, welcome to video 2 in this overview of reproduction. We'll start with control of function. Basically, reproduction is a neuroendocrine phenomenon. The hormones determine what's going on functionally with the reproduction. So it all starts with the hypothalamic pituitary gonadal axis, and this should be somewhat familiar to you, at least in terms of the hypothalamus and the pituitary from food to fuel. The hypothalamus communicates with the pituitary, and the pituitary, in response to that communication, communicates with the gonads. Okay, hypothalamic pituitary gonadal. The hypothalamus produces gonadotropin-releasing hormone, GnRH, henceforth known as GnRH, and that is transmitted to the pituitary, and GnRH results in secretion of FSH, follicle-stimulating hormone, and LH, luteinizing hormone. So the more GnRH the hypothalamus is secreting, the more FSH and luteinizing hormone the anterior pituitary is secreting. That FSH and LH act on the gonads, and you produce testosterone and estradiol, and that is largely sex dependent. Note that these feed back upon the system in the same way that you had feedback mechanisms in food to fuel. So testosterone and estradiol feed back negatively upon the pituitary, so that the more you produce here, you get a negative feedback upon the pituitary, which keeps that secretion of FSH and LH under control. And it also feeds back upon the hypothalamus. And so the more testosterone and estradiol you have, the less GnRH you are producing. Inhibin is a hormone that we'll talk about a lot more in later lessons. Activin, and it negatively feedbacks upon the pituitary. Activin, not as much known about, but it has a positive feedback upon the pituitary, and we'll address that. We'll address these later. But you'll notice that the control overall is primarily through negative feedback mechanisms that keep this secretion under control. Okay? As far as the anatomy is concerned, you're talking about a portal circulation here, where your GnRH is produced in the hypothalamus, and then it is transported through this portal vein to the anterior pituitary, where it stimulates the release of LH and FSH, and you will also notice there are some other relevant hormones here. Growth hormone, GH, we'll talk about later. Dr. Morgan will address that. PRL is prolactin. We'll address that with pregnancy. It has to do with milk, with lactation. That's about all I have to say as far as that is concerned, and I believe that is a review for you guys. Again, GnRH from the hypothalamus. The more GnRH you have, the more FSH and LH you secrete from the anterior pituitary. Okay? All right. Having said that, let's talk a little bit about the chronology of sexual development. You start with an embryo here, and as an embryo, much of your sexual differentiation takes place. You develop a Wolffian duct system if you are a male, and this becomes the urogenital structures, the epididymis, the vas deferens, and so on and so forth. We'll talk about a lot more later. If you are female, you have a Mullerian duct system, which develops into the uterine tubes, the uterus, the cervix, etc. Okay? So a fair bit of physical differentiation there. Then you enter a period of sexual quiescence as a child. Okay, for the first, 9, 10, 11, 12 years, there really isn't a lot going on sexually. You're just using all your energy for growth. And then you hit puberty, where sexual development resumes. Your primary sex organs develop further. Secondary sexual characteristics become more prominent. And then you enter the adult phase. These are your prime reproductive years, sexual maturity. And this phase is characterized as being climacteric. That means that it reaches a peak probably about the time that you're about 30, and then declines slowly after that until reproductive function essentially ceases when the equipment ceases to function. And if you're female, that is characterized as menopause. Okay? So let's go back to puberty, and let's talk a little bit about that phase. This is basically where you transition from infantile to an adult state, all the physiological, morphological, behavioral changes that occur as the gonads develop and change. Okay? It is characterized by a growth spurt. So here we have a graph of growth in centimeters per year, as an average, of course, as a function of years of life. And as you become older, through your first 9 or 10 years, you start growing as an infant pretty rapidly, and then that rate of decline decreases, and then you hit a peak where you get growth spurts in the male and the female. The female occurs earlier, the male occurs later. And it's thought that this is the reason why males tend to grow larger than females, because they spend a longer period of time in this pre-pubescent stage growing, and so that means that their growth plates are open for longer in their bones, and so their bones grow longer and they grow more. As a result of that, they tend to grow larger than females on average. So the female growth spurts hits earlier, the male hits later. This allows for greater growth. If we look at what's going on in the male during these years where you're approaching puberty and afterwards, you can see that a lot of it starts with an increasing level of these gonadotropins, the LH and the FSH. So you increase pretty much linearly over these years. As that happens, you eventually hit a point where the testicular size is increasing, and you are suddenly producing a lot more testosterone. So you can see you get this gradual, small increase, and then boom, it takes off when you hit puberty. And as that testosterone secretion takes off, you start to develop the characteristics of puberty. Pubic hair starts to grow in, along with facial hair, more growth and of the male genitalia. So here we have penile growth, the testicles, the scrotum, etc. You tend to develop an Adam's apple during this period. Of course, sperm production goes up. And of course, you hit a growth spurt during this period as well, with an increase in muscle mass, broadening of the shoulders. Okay? In the female, it isn't that much different. A lot starts with these gonadotropins, and again, they increase pretty much linearly over time. And eventually, again, you hit a point where the estradiol production just takes off. And this results in, again, a number of changes. We have breast development here, growth of pubic hair and axillary hair. You have your enlargement of the external genitalia, just like you do with the male, in this case the labia. And of course you have a growth spurt and a broadening of the hips, distribution of adipose tissue, okay? And you'll note the beginning of the menstrual cycle here. That seems to begin when this estradiol gets high enough to start to stimulate the cycle. We'll talk a lot more about that in a future lesson. the female reproduction lesson, basically. It'll be a large focus of that, and it is a large reason for the fact that it's a double the normal length of a normal lesson, the complications involved there. So if we look at the gonadotropins, since they seem to be driving this, and we look at them over time, you can see that the secretion does change depending upon what stage of development that you are in. So during the pre-puberty stage, you have a relatively low concentration of these gonadotropins, and it's relatively constant, okay? In mid-puberty, there's this big diurnal effect where you get a big peak in these gonadotropins during sleep at night, okay? And the concentration on average overall is higher than the pre-puberty stage, largely because of that. And then you'll notice that in adulthood, we're back to a more or less stable average concentration, and that average is higher than pre-puberty, but a lot of it is coming in spikes where you get a big production and then you return to close to pre-puberty levels. These tend to be particularly large at night, but they take place during the day as well. It's kind of a spiky behavior, okay? And this behavior in all of these changes is directly related to the pattern of gonadotropin release. High gonadotropin release means, GnRH release. High GnRH means high LH and FSH. Low GnRH means low LH and FSH, and even the spiking behavior really results from spiking of the GnRH. Okay, so when we look at these changes in the gonadotropin levels, bear in mind that it all starts with GnRH from the hypothalamus. So if we look at sort of a summary of what this looks like over life, during childhood, again, low in the female, low FSH and LH. And then it comes up as we approach puberty, okay? And we get this gradual linear increase. And then notice during adulthood, these monthly surges, these are the menstrual cycle, the monthly surges that come with that. You'll notice this late phase where FSH and LH get really high one last time. That's because there's a feedback in the female from estradiol. So when you hit menopause, you stop producing estradiol, estrogen, and that, as we showed on a previous slide when we were talking about control, results in less negative feedback upon the anterior pituitary and the hypothalamus. Because of this lack of inhibition, this lack of negative feedback, you get a large concentration of LH and FSH. We'll talk about menopause more in a second. Notice the testosterone here, low during the childhood years, rises with the increase in LH and FSH. During puberty and during adulthood, relatively high. This graph kind of misleading. The amount of testosterone does start to gradually decline, starting about when you're about 30. But nevertheless, you can see this big drop off with older age. Okay? So having looked at that, we might ask, okay, this puberty stage, really interesting. You know, what is really causing this sudden increase in basically testosterone and estrogen that results in these changes with puberty? Well, as it turns out, it's because there is a decrease in the sensitivity to this negative feedback, this negative feedback of the sex steroids, the testosterone and the estradiol, upon the hypothalamus and possibly the pituitary. So if you look at gonadotropin release on the y-axis here, and this is concentration of sex steroid. And if you look at what happens to gonadotropin release as you increase the concentration of sex steroid, as you increase the sex steroids, the gonadotropin release goes down, and this is because of this negative feedback of the sex steroids upon the hypothalamus and upon gonadotropin release. Well, if you look at it in the adolescent, it takes more sex steroid to cause this inhibition to take place. So there's a decrease in the sensitivity to these sex steroids. There's a decrease in the negative feedback. And if you look at the adult, the sensitivity is even lower. It takes even more sex steroid to inhibit gonadotropin release. And again, this is just a different way of showing the same thing. During infancy and childhood, you have a fairly high sensitivity to these sex steroids. The inhibition is fairly effective. And then that effectiveness, that sensitivity to these steroids goes down as you go through puberty and reach adulthood, meaning that the sensitivity to the sex steroids goes down, so you're secreting more of the gonadotropins during these periods. Okay? All right. So you might ask yourself, why does that sensitivity goes down? And the answer is nobody really knows definitively. This is an area of research that is of course currently continuing. Maybe by the time you're my age, this section of this talk will be considerably longer. But here's one possible mechanism that fits sort of the current theories for why this happens. It all starts with a molecule called leptin, and this is produced by fat stores. So the idea is that as a child, a lot of your energy is going into growth, and you don't have enough energy to devote to reproductive function, okay? So the thought is that when you increase your fat stores as you approach puberty, that's a signal for your body, meaning, okay, he's a big, strong male or female, he or she, and they're ready to start their reproductive function. And so leptin increases, its release is increased with increasing fat stores, and as it increases, it acts upon what are known as KISS1 neurons in the hypothalamus, and these produce kisspeptin. And the more leptin you have, the more kisspeptin you produce with KISS1 neurons. And so the GnRH neurons in the hypothalamus, the GnRH secreting neurons and producing neurons, have receptors for kisspeptin on them. And the more kisspeptin you produce, the more GnRH you produce, and the more your pituitary secretes LH and FSH. Okay? So you have two competing things going on. You have negative feedback from the sex steroids, and that's reducing GnRH release. But as you grow and you get more leptin involved in this, and that produces more kisspeptin, the kisspeptin stimulates even as the sex hormones are inhibiting. So what the kisspeptin does is it effectively competes, and it makes the sex steroids less effective. You've got kisspeptin increasing, you've got sex steroids decreasing. The more kisspeptin you have, the less effective the sex steroids are. And so eventually you get to the point where you're producing enough of the sex steroids to produce puberty. And that is how puberty is initiated. Eventually you hit this point where the testosterone production takes off, because presumably you've got enough leptin producing enough kisspeptin to overcome the normal feedback that testosterone has upon gonadotropin release. Okay? The same thing for the female with estradiol. Estradiol usually inhibits FSH release. You produce more leptin. That makes that inhibition less effective, and eventually estradiol production takes off, and you hit puberty. Okay? So that is one theory about how this happens. Okay? It is interesting to note that even before puberty, pre-puberty, your gonads are capable of producing adult levels of sex hormones. Pre-puberty, your pituitary is capable of producing LH and FSH. The key to all this seems to be the fact that your hypothalamus won't let them produce adult levels of LH and FSH, testosterone and estradiol. It's not ready to produce adult levels of GnRH. The feedback inhibition has to be relieved first, to some extent. Of course, it's still always there. It just becomes less sensitive. All right, let's talk very briefly about menopause, and I'll wrap this thing up. Menopause is the cessation of reproduction, reproductive, not sexual function in a female. Okay, it arises from a cessation of function from the ovaries, and what this means is the ovaries basically run out of eggs. They stop producing estrogen, and they basically their function collapses. Okay. Menopause produces a number of characteristics, many of which I'm sure you're familiar with, like hot flashes and mood swings. We have talked a lot about osteoporosis already, so that obviously is no surprise here. Those signs of menopause are a result of the fact that there are a lot of targets for estrogen around the body that are no longer getting estrogen. The reproductive organs are targets for estrogen. I think the female reproductive tract, no surprise to anyone. Do bear in mind the male reproductive tract also is a target for estrogen. There are effects of estrogen in the male reproductive tract. It affects etheric ductal fluid absorption, germ cells, and differentiation. So bear in mind estrogen there in the male and has function. Bone, we talked about in movement and mechanics. Estrogen decreases apoptosis of osteoblasts, and so that maintains normal bone function. Without estrogen, you get fragile bones. The vascular system, we didn't talk a lot about in the cardiovascular block, but there is some vasodilation due to estrogen, and there is some protection from plaques. There is an immunosuppressive function of estrogen, which gives you some protection from the development of plaques in the cardiovascular system. And there is an effect upon the central nervous system that affects growth. It does supply some neuroprotection, and related to the cardiovascular effects, you do get better perfusion of the central nervous system with estrogen around, and there is some stroke prevention that is involved with the presence of estrogen, probably related to this plaque protection function here. Okay, so having said all that, that is all I have for this video and this lesson, I will see you guys in the rooms.